Hi, this is Dr. Eric Dein from Baltimore, Maryland, coming to you with another update from ACR Convergence and coming to you for Room Now. And today I'm going to talk about posters in this morning's rheumatoid arthritis poster session, and starting with poster 0755, entitled Exploring the Significance of ANA Positivity in Medical Management of Patients with Rheumatoid Arthritis. This was an excellent poster put together by a medical student, Dr. Paknikar from the Mayo Clinic. Did a fantastic job of putting together and presenting this information, and I think a highly relevant topic for clinicians and people who think about the population of patients with rheumatoid arthritis. She took a look at patients in Olmsted County, the Mayo population that had rheumatoid arthritis and had ANA testing. They found that 161 patients were tested. Who was likely to get tested? They found that female younger patients were more likely to get an ANA checked when they present with inflammatory arthritis. And in that group, they found a 25% ANA positivity rate. ANA positivity was similar in patients with seropositive or seronegative rheumatoid arthritis. Again, this was not standard checked across the board. This is just a retrospective analysis of what the practice patterns were. And the question is, how are those patients treated? Is there a difference in treatment that was provided to those patients and in recognition of their disease when they have a positive ANA? They found that patients with a positive ANA took a longer time to fulfill the RA criteria before they met enough that they could be labeled with rheumatoid arthritis. And their treatments were significantly different than patients without a positive RNA. For this analysis, because of the numbers and to simplify, they focused only on the seropositive patients. So these are patients with seropositive RF or CCP in addition to positive ANAs. What treatment would you start those patients on? Well, it turns out they are, in practice, more likely to be placed on Plaquenil monotherapy rather than methotrexate monotherapy in similar patients without ANA positivity. So if you have a positive ANA and you're seropositive, 44% of them were started on Plaquenil compared to 23% with methotrexate. I'm sorry, 23% with a negative ANA started on Plaquenil. If you are seropositive with a negative ANA, you are likely to be started on methotrexate 71% of the time versus 48% of the time if you're ANA negative. I'm sorry, if you're ANA positive, you were significantly less likely to be started on methotrexate, 48% versus 71%. So what that means there is that patients that have an ANA positivity are treated different in their treatment of rheumatoid arthritis, even with seropositive labs. So they are less likely to be started on a frontline therapy of methotrexate, more likely to be started on Plaquenil. I don't know the information based on this. Was there any factors in these patients, any other labs that made them think that there was an overlap with SLE because of the ANA positivity? In which case you might want to think about maybe having Plaquenil on board for UCTD type symptoms and progression to SLE. But these are patients with seropositive labs that you would think methotrexate would be beneficial. They would help treat the disease early. And I think it was surprising to me that these patients were not treated early on with methotrexate or another conventional DMARD beyond just Plaquenil. But it was, I think, a sign that we should be thinking about seropositive disease similar across the board and recognize that ANA positivity is very prevalent. 25% of the patients that were tested in this population and should probably be treated as rheumatoid arthritis patients with appropriate therapy. This is Eric Dein from Room Now. Thank you very much for your time, and we look forward to checking in with you throughout the conference.